Good morning, everyone. Thanks for joining us. So we're going to go ahead and get started. So we are looking forward to today. We have a few speakers today. Before we get started, I wanted to just go over some reminders. Please make sure your full name is on your Zoom profile so we can count your attendance for the day. You're welcome to have your cameras on. It's always nice to see your faces. Please remember to be respectful and attentive to our speakers, staff, and your fellow students. Rude language or bullying, inappropriate behavior will not be tolerated. Please keep yourself muted when not speaking. If you would like to speak, please use the raise your hand function and we will call on you, time permitting. And then please use the chat function to ask or answer questions, and we'll do our best to answer all your questions. So our first speaker is Dr. Diane Chan. Dr. Chan has enjoyed caring for patients for the past 2 decades as a pediatrician with Kaiser Permanente. She also splits her time teaching residents and medical students. So welcome, Dr. Chan.
Thank you so much, Sam. Is my audio still fine?
Yes, sounds good.
Okay, perfect. Thank you, guys. And I believe, am I kicking off this session? Is that right?
Yes. So they had orientation on Monday, which was pretty brief. We just went through some questions. Dr. Eric Williams, who's our chair, he spoke a little bit about the program, but you are our first official speaker.
Perfect. Hi, everyone. I am so excited to join you guys this morning. Like Sam said, if you would not mind, turn on your cameras. I get it. I have 3 young adult kids. It's summertime. Maybe you're doing this from the comfort of your home or your bed, but I would love to see as many of you as possible. I want this to be a really interactive session. So please throw stuff into the chat or do the thumbs up reactions, whatever it is. So like Sam said, I am a pediatrician in the Roseville area, and I have been doing this for 23 years, so more years than you guys have been alive. And this is really one of my favorite times of year in June and July. July 1 to June 30th is typically the academic year of a medical school of residents. So this is when I start teaching, and I teach at UC Davis Medical School. I love giving talks to future healthcare professionals. And how this came about, this talk, so I'm going to be talking to you for the next hour. I'm going to keep some time for questions. But the reason this came about was because this was a program that started with Dr. Williams, he probably mentioned, at TPMG or Kaiser Permanente when he was there. So I sat through many of these talks, and it's so amazing that you guys have firsthand exposure to physicians, people in different areas in healthcare, for them to talk about what they do day to day. I realized though, and I realized after listening to a couple of talks, that we were using lingo that you guys may not understand or know yet, or maybe I'm totally wrong and you guys already know about this. But that's why I reached out to Sam and said, hey, can I give an intro talk to really give some of the background that hopefully will give you the foundation to understand future talks from my colleagues, from nurses, from PAs, from whoever your speakers might be, because we just start using words thinking people understand them. And I'm sure you guys use lingo that old folks like us don't understand. So I just wanted to establish some type of background. And so I do want this to be interactive. You already understand these words, fine, we can move on. Okay, so that's the reason for this first session. And Sam, you can start that first slide with what are you talking about? Thank you. So literally that simply said, it's what do you guys mean? Can we slow down? And I would encourage you, the folks who are being speakers, please ask. We're doing it for you guys. We love to mentor, to see who the folks who are going to be taking our place, in the future. So if you're not understanding something, please kindly ask. And same thing for you today. I'll explain why my technology is a little down this morning, but Sam will kindly monitor the chat for us of their questions. She will ask me, and Sam, feel free to throw in a question if you think that will help, along the way, or we can save them towards the end. Whatever you want to do, I'm super flexible. I do this talk every single year, and so I committed to this date. And it turns out to be the date my daughter is moving out of her dorm. She's at Stanford University finishing up her sophomore year. And for one reason or another, it just happened that she was moving out today. So I drove down from Sacramento at 6 a.m. today. Traffic was terrible. And now she got me a room in one of the libraries. So that's what you're seeing. This is Green Library on Stanford campus. So that's why my technology is a little challenged. I've got the phone, I've got the laptop, but I'm glad you guys can hear and see me. So here we go. There was a fire alarm when I walked in. So if it goes back up, I hope we'll just ignore that and keep going. Okay. All right, you guys. Okay. Next slide, please. Okay. Members of the healthcare team. We start throwing initials around. We are like, who is who? And again, maybe you guys already know this. And I guess maybe before I start, can I just get a poll? And I guess you can throw it into the into the chat. Maybe I'll do it this way. Let me do it to everyone. Who is thinking? And I know this is all like we're just planning for the future. Nothing is set in stone. But if you're thinking, we can thumbs up on yeah, okay. So I'm going to throw these categories in. And if you're thinking of a career in this, will you just thumbs up that area, please? So I get an idea. Perfect. Thank you for responding. So I've got physician, NP, PA, MA, RN, LVN, or something else. We're not sure yet, but something in the healthcare field. Okay. Thank you. Thank you. Very cool. So is this something, who said the something else? Go ahead and you can type that into the chat or unmute yourself, but what is the something else that you're interested in doing? Very good. Okay, just exploring, totally, don't have to commit. I love that, actually. Okay, so I see a wide smattering here. So for the focus of my talk, I'm going to be talking more about the timeline and the course that it takes to become a physician. But as you can see, there are certainly very integral parts of the team. NP, nurse practitioner, PA, physician assistant, MA, medical assistant, RN, registered nurse, and LVN, licensed vocational nurse. Okay, those are, and then there are plenty of other members as well, but those are sort of the, pharmacy, very good, a very key core team. I prescribe every day and rely on my pharmacist to help me, whether it's with the dosing or look at what other drugs the patient is on, and sort of help me figure out the medication. Something in surgery, very cool. So it could be a surgeon, and we'll talk about who else is in the OR in a little bit. Okay, next slide, please. Back up one, I think we skipped two. Back up one. There we go. So like I said, this is going to be specifically a journey into becoming a physician. So just in case you're not aware, so you guys are in high school, so 4 years of undergrad, and then medical school, although that can be different. There are combined BA, MD programs, right? And so that would be applying to a program that is typically 3 years of undergrad, and then you're already sure you're going to go into medicine. So then you continue on into medical school. And there are programs throughout the country that have that, which is kind of cool, because then once you get in, you don't have to worry about applying again into medical school and taking the exams. You still have to take the exams that we'll talk about on the next slide, but you don't have to do spectacular because you're already in a program. Does that make sense? Okay, so then 4 years of undergrad, typically 4 years of medical school, And honestly, there are lots of schools now that are, not lots, there are several that I know, including one at UC Davis, that medical school is 3. So I think we're realizing, we as in the medical community, realizing that it's a long way to get through all these bullet points. And at some point, you want to earn your money. I'm sure your parents want you off their payroll at some point. And you want to start your life, you want to start earning a paycheck, you want to start your own family. So that is a lot of the reasons why people are trying to shorten, still have great training and still give you the knowledge, but shorten up the duration of the medical school process. Okay, so after that is internship. That is does anybody know what that is? What internship what that refers to? Okay, that is the first year in your residence. So after medical school, typically during the 4th year, you apply to your residency. And intern year is the first year of that residency program. Okay, and it's typically in that field. So I'm a pediatrician, and we'll talk about that in the next slide deck. But so I applied to a residency program, and the first year I was called an intern. Okay, and then year 2 and 3. So it's all of it is in pediatrics. There's some programs, especially surgery ones, where if you want to become a urologist, that's very specialized, the first year you do it in general surgery just so you get knowledge of just surgery in general. And so that's why your internship could be different from your residency. Does that make sense? Okay, I see some nodding heads. Okay, thank you. And then the residency is a chunk of learning and skills and patient interaction that you do for that topic that you've chosen. And we'll talk more about sort of how to choose or some ways to think about your residency. Okay, and at that point, you're a licensed physician. You can come out and practice, you can get a job, you can see patients, prescribe medication, and that's it. Some, though, will choose to go on and specialize in something else and do a fellowship. Okay, so an example is, so I did my residency in pediatrics, and at that point I came out, got a job, and that's when I started working at Kaiser. If you want to do something within pediatrics, like let's say you want to do cardiology, then you do a fellowship in pediatrics cardiology, and then you come out and you see heart issues in pediatric patients. So that's what fellowship. And some colleagues will just choose to be in school forever, and you can really, really start specializing. I have a friend from medical school who she did her residency in surgery. Then she did a fellowship in plastics. So like really refining that surgery, right? Plastics is when you like make it everything beautiful and hide the scars. And then she decide to do a fellowship in hand surgery. So she did like, I think 12 years more on top of it. And now she works in Beverly Hills and makes sure that everybody, you know, all the stars have beautiful hands when they have a surgery or needed something removed. So you can really, really see how you can really specialize. Okay, and then gap year, I think you are familiar with that term, right? After undergrad, if you're not yet ready to apply to medical school, or if you want to buff up your CV or your experience, because it's pretty competitive to get into medical school, you can take a gap year or a couple, depending on your situation. Okay, and then the right column is sort of who those people are. During internship, you're an intern. During residency, you're a resident. During fellowship, you're a fellow. And the attending doesn't belong with the gap year. The attending, or the word attending, goes with sort of now the big honcho, right? Like at the hospital, he's like the head of the team. He or she is the head of the team, the leader of the team, and it's usually called an attending physician or an attending. And frequently, the intern will be talking or asking the attending, like, does this plan sound good, and stuff like that. They are sort of the big bosses in the hospital or the clinic setting, and that's called an attending. Okay, any questions about that? Otherwise, we'll move on. I don't see anything in the chat, so let's go ahead and look at our next slide. Okay, and these are the tests that are along the way, and it's called MCAT, which is the Medical College Admissions Test. that you take in order to apply to medical school. That's usually taken third or fourth year of your college year, or it could be during your gap year, but you need the scores in order to apply for to medical school. Okay. And then USMLE is the US Medical License Exam, or in other words, boards. And there are 3 separate tests that you have to take. The first 2 are during medical school. Third is typically, and things change all the time, but it's typically the first year of your residency. Or what did I say? That's called internship year. So you take that test then to make sure you're still proficient and you still have the fund of knowledge. Okay, next slide, please. I hope you guys have some questions saved up. We'll save some time for questions. Okay, and I just wanted to give you a brief glimpse of the day in the life of a physician. And just, again, making sure the words, the whole point of this talk is to give you words. Like I said, it's a glossary, like terms, vocabulary that you may or may not understand. So now we're in the hospital. You know, they're patients who stay overnight because they're sick. They have to be there maybe for days. So in the morning, typically, the person who's who's least senior, so the least senior person, usually the intern, will pre-round. Okay, and that means go around, see the list of patients on his or her service, see how they did overnight. You're looking at their vital sheet. You're talking to the nurse. You're talking to the patient to see how they did. You're gathering this information. So let's say you have 8 patients, and so you got to make time. And that's why you're there at like 6 a.m., crazy early, just to see all these patients. And then the whole team will round. And that's the verb. They will all round together, but the noun is they'll go on rounds together. And it's literally around the hospital ward, and the intern or whoever did the pre-rounds will present that patient. And I don't know, you guys, maybe some of you watch like Grey's Anatomy or something, right? That's when all 3 or 4 people are in the patient room and somebody presents like, this is a 32-year-old admitted for appendicitis who had surgery yesterday and now has a fever. You know, that's when they give that spiel. That's during rounds. Okay, does that make sense? Okay, and then at that point, we're problem solving. You know, she still has a fever. What do we do? And the whole team sort of chimes in. Okay, what could it be to? Is it the line that's infected? And then you basically get your list of to-dos for the day. And then, or you can call your consultants. So usually the team that is rounding are generalists, meaning they sort of are in charge of everything on the patient. So in my example, the patient had appendicitis, so had surgery, now is having a fever, and maybe they already had diabetes. So then your specialist, your consultants would be those people taking care of those pieces. So the surgeon who did the appendix removal, maybe we need to consult infectious disease doctor to see what antibiotics for the fever we should start the patient on. And then we're going to speak to an endocrinologist about the patient's diabetes. So that's part of your day too, like looking at consults or consultants or putting in consultations. And inpatient, that's self-explanatory, I think, but that means inside a hospital, okay? It's also called a ward. It's also called on service. All of those words imply that it's the patient that's in the hospital. On the flip side is the outpatient. So again, another self-explanatory term, but you're not in the hospital, you're outside of it. And these are the offices. So many of you probably went to see your pediatrician or will be this summer. I know I see a lot of my patients during this time because you're off from school. You don't have to miss AP Bio to come see me. So, so I see a lot of patients for checkups and physicals, and that's called the outpatient or clinic or offices or MOB. There are lots of words to imply like you're not staying in the hospital. You're going to come see us and go home. Okay. And then ICUs, inpatient, right? Definitely, and it stands for intensive care unit. These are the patients who need extra level of support and care. These are the ones where, you know, the room is a private room, it's all glass, the beeping everything's because they're closely monitored. And you can have one for pediatrics. So that's the PICU, PICU. the NICU, the neonatal ICU. You can have a MICU and a medicine ICU. You can throw any letter in front of that, and we probably have that. Okay, so that's sort of words to describe the hospital. Okay, next slide, please. Specialties. Remember what I said about like the generalists. These are sort of the physicians who learn about everything. And sometimes those words are confusing. And if you're thinking of what specialty, and again, you don't have to at this point. I just want to expose you to certain words and words that I frankly find confusing still. So I wanted to throw that out to you. So internal medicine. These are sort of the so if to you, a pediatrician would be an internal medicine to parents. So those are the doctors who see older, like usually after 18 years old, different diseases, different pathologies. So they're the ones who see adults. Okay, so they could be called internal medicine. Sometimes it's medicine. Like when you say, ask someone like, oh, what is your specialty? They might say IM, which is internal medicine. They might say medicine. And sometimes that's confusing because you're like, yeah, I know you're a doctor, but what is your specialty? And they just keep saying medicine. So medicine means internal medicine. Okay. Family medicine is a practitioner who sees literally a combination of pediatrics and internal medicine. So they see the whole spectrum. They see someone, a baby who's hours old, all the way to like someone who's 99 years old. So they you know, and they take care of all members of the family. That's what that's where the term comes from. So they can see the baby, they can see the mom who just gave birth, they can see the dad, they can see the other siblings. So that's the idea, that you just have one doctor for the whole family. So that could be family medicine, family med, or at Kaiser, we call that AFM, adult family medicine. So lots of different words thrown at you. Just know that means the same thing. Okay. OBGYN, is that a term that you guys have heard? Yep, I'm seeing. Okay. And you can say it different two ways. OB is usually always said as the letter, so OB. And then after that, you can keep spelling out the letter. So OBGYN. Or some people will say OB-GYN, and you just say the GYN as a word, OB-GYN. And that stands for obstetrics and gynecology. So these are the folks who see women and women who are about to have babies and follow them through pregnancy. Okay. And sometimes you'll hear the word interventional in front of many specialties. And that just means something that's procedural. So one of you might be interested in radiology, right? Those are the doctors who read x-rays and MRIs and CTs and all the imaging. But you're like, you know what? I'm great with my hands. I like doing procedures. Okay. Interventional radiology. That means if somebody is in their needs to like fluoroscopy, I know I'm throwing out words, but they need to visualize a vessel better. So the radiologist will insert a catheter, put in some dye, and that way they can visualize the anatomy of the kidney. So they do intervention, they intervene, it's interventional. Cardiology, same thing. You might think the heart's awesome and cool, and you want to be a cardiologist, but you also want to do something. And those are the folks who will do something in the cath lab and make those vessels when people are having heart attacks or blockages, open that up. So another thing to think about. So there are very, very many options. And then, oh, I skipped one, didn't I? ENT, ear, nose, and throat, right? Those are the folks who talk about those, who specialize in those organs. Or sometimes they're called H&S, head and neck surgery. So lots of words for the same thing. So I just wanted you to be aware of that, especially when you're in the hospital setting. I think, frankly, the ENTs, ear, nose, and throat surgeons, so I'm told, were sort of like, we do more than that. We don't just do 3 things. So they want it to be known as an all-encompassing head and neck surgery. Okay, now going back down to the last one, EM, ER, ED. All saying the same thing. EM is a specialty. So if you want to be a doctor who works in the emergency room, that's what ER stands for, which you obviously know from many TV shows and stuff. Your field that you're licensed in is emergency medicine. And then that way you get to work in the ED, emergency department, or in the ER, which is the emergency room. So again, I don't know why we do this to ourselves, but there's lots of different words for stuff. Okay, I think that's the last slide that I have in this deck. Any questions, or do you find that helpful, or do you have more? Have you heard of words that you're like, I don't know what they mean? Ah, excellent. Okay. Okay, I am reading your question. Thank you. What course or subject would you recommend taking undergrad, higher ed, if you're planning to be a physician? And what is the flexibility like? How many hours are typical in one day? I love it. I love it. You're already thinking ahead. Okay, I'm going to pause and answer that with my next slide deck. I have a couple of slides to address that. So we'll come back to that. Any questions specifically on, well, not specifically, but just any questions at all? And Sam, will you, let's see, my next one is the pediatrics and pediatricians. Thank you. Okay, so we're going to slide into pediatrics and pediatricians, which obviously is near and dear to my heart. I've been a pediatrician, like I said, longer than you've been alive, 23 years. I find that most of you, because you see it, most of you see a pediatrician, right? You guys see some of you could see a family medicine doctor, but you're sort of familiar with what we do. But I just wanted to give you a broader insight, because I think because of that, many of my patients, I may or may not have a patient who's listening right now. So I won't call you out, but I'm super glad to see you here. I always get asked like, hey, I want to be a pediatrician. What is that like? So I wanted to share that with you guys. Okay. So again, open to questions. And so I'm just going to talk about a day in my life and sort of what it took to get here. Next slide, please. So this slide deck was created before I knew I was going to give that previous talk. So I'm going to just back off from pediatrics for a little bit and talk about in general. How to decide on a specialty. Again, this is very early for you. You don't have to do this. This is a talk that I also give to medical students. And at that point, they need to be really nailing down what they're interested in. But I find that more and more kids these days are super advanced, I think, because of access on the internet or just your access, because you're in this program. You can talk to different physicians, or you have access to sort of who's doing what. And it's just super cool to start thinking of what you might want to be interested in. Okay. You don't have to lock in until medical school, second year, probably, because you want to do some rotations in that specialty that you're interested in. So you have plenty of time, right? Because you've got at least, 6 years and after you graduate high school. So again, plenty of time, but start thinking about it. So I think the big way to categorize it and divide it up is medicine, surgery, or psychiatry. Those are sort of the broad topics. And then you want to think about who the question was also asked, which was great. Like, where do you see yourself? Like in a clinic, which means from the other side deck, like an office outpatient, right? Versus an inside the hospital setting. And so I would encourage you, I know Kaiser, some of you will be with us in a couple of weeks, and you get to go to different sites. Like and again, you don't have to decide, but just like get a feel, like what feels good. Are you excited when you're in the ICU, or are you overwhelmed? Like, oh my God, there are too many things that are beeping and everybody's super, super sick and that's scary, or you love it. So start thinking about that. Like, do you want to be inside the clinic or in the hospital? Oh, these are only online students. So sorry. Okay. And then what your work day, and I think that's what the question was about, how many hours in a typical office. And so do you like the work days where like for the last, I don't know, a billion years, I know that I have Wednesday afternoons off and Friday afternoon off. And then I see patients the other times of the day, which is helpful, like especially with kids, like I can sign them up for a ballet class Wednesday at 3 o'clock because I know I can take them, okay? Or are you good with shifts? Like you like to work in the ER. So then you just know you're okay with working from 7A to 7P, but then switching to like midnight to 8, and then switching to like 10 days off, and then coming back and working 8 shifts in a row. Like, are you that type of person? You can sleep day or night. So these are questions that you can start to answer for yourself. And then the level of patient interaction. I see patients every single day. I see them, I talk to them, I touch them, I'm, in a room with them, we're talking all the time. If you don't love that, there are plenty of fields in medicine that you can do. You can, like being a radiologist, if you're not the interventional one, right, who's putting in the catheter, you don't even need to talk to a patient. You're reading films, you're in front of your screen, so that's minimal. So it's a pathologist, right? A physician who's a pathologist who gets a sample from the surgery, from a surgeon who's removed a part of the kidney and needs to know what cells are growing in there. They're not interacting with the patient because the patient's asleep on the OR table. They're interacting with the surgeons. So that's also what you decide on. And also the duration of the patient relationship. Like I love this time of year because I'm getting graduation cards from people like you guys who are in high school or have graduated. I know you guys haven't graduated, but I get graduation cards because I've literally seen that patient for 18 years. I start seeing them when they were like 2 days old, and I've seen them for 18 years. I love that. That is and then I still get letters when they're in college and they tell me what they're up to, and I see their kids. Like that's the joys of my job as a pediatrician. Maybe that doesn't do it for you, which is fine. So then you pick ER, or you pick the docs in the ICU. You see patients when they are at their sickest, at their worst, when they're having the most terrible day in their life, and you save them. You get them better. They leave, and they honestly never want to see you again because they never want to be back in the PICU, right? Like they don't want to be that sick again. So that's the level of your interaction. Like you help them. You're like that hero, like you just step in, you swoop in, and you save their life. And so which is for you? Again, not asking you to answer those now, but just start thinking. Okay. And then the fit for your personality, right? What is your, if I had 10 days off, like some of my ER colleagues will have 10 days off, and they're like off like mountain climbing, mountain biking, that they love that. I don't know what I would do with 10 days off. I'm used to a routine. I need a routine. So then that wouldn't fit me, but my job fits me. So again, thinking about these things as you explore different things in medicine. And so back to your question about the typical office day, it really depends. It depends on what kind of job you have. So on the days that I work, I get in there around 8, and depending on how many patients I see and how many charts I have to do, I'm often there till 6:30. So that's a long day. These days though, with advances in AI, I've been helped out with my charting through AI software. So I'm charting less, so I get out earlier. Yay. But you also heard my flexibility, right? I'm part-time. So it also leaves me time afternoons. And when my kids were younger, they're older now. They're in college, like I said, and 2 are headed to college next year. So when they were younger, though, I had all of Tuesday and all of Thursdays off. So again, allows for, like you said, leisure activities, things outside of work. So you can really find the job that fits your needs. Maybe not right from the start. You gotta, you gotta get a job, and that may not be your most ideal job, but then from there you can really develop it. And then the office day, and a lot of the times you can also look for a virtual job, and that means people who are just not just, but they're doing virtual appointments on the phone, video. So those have more flexibility as well. So I wouldn't let your sort of worries about what the day is like sort of affect your ability to go into medicine, because it's just ever changing. It's changing so much. Okay, next slide, please. I think I already touched upon this on the other slide deck, but here we go. High school, 12 year. I think one of my patients who was going into kindergarten or first grade asked me how many years I went to school. And I told him 23, and his eyes were open so big. He was like, oh my gosh, like he was in first grade. But 12 grades of high school, 4 years of undergrad, 4 years of traditional med school. Again, they could be combos and shorter, and 3 years of residency in pediatrics. And we talked about if you want to further specialize, you can do a fellowship. Okay, next slide, please. And as I was alluding to, what is pediatrics? Pediatrics is in terms of who I see from babies through all those stages, babies who are adorable, to toddlers who tantrum, to that little boy is probably, 3, 4, 5 years old. Then there's school age, they're in elementary school, they get to be the awkward preteens, then the full-fledged teenagers who have attitudes and headphones on and don't want to talk to parents or adults, right? I see all of those. And as you can imagine, there are different disorders or concerns, right? Like the babies have their thing. Oh my gosh, are they not eating? They're not breastfeeding. We don't know what they're not communicating all their needs. And then you get to a very, opinionated teen who's saying, I have headaches and this hurts and that hurts and I don't want to go to school. So it's the whole gamut. And so the reason I love pediatrics is it's not the same diseases. So like when a 2-day-old catches a cold, it's going to be very, very more severe than if one of you catches a cold, right? Like we're like, okay, drink more water, take some Tylenol, get some rest. But for that baby who can't breathe very well, they could very well be admitted to the hospital. So I see the whole range. Next slide, please. Feel free to throw any questions into the chat. I will come. I have it pulled up on my monitor, or Sam can also let me know. General pediatrician, like I said, I'm office-based. I see you all, and you're probably familiar with why you come to the doctor, right? Checkups to get clearances for those sports physical that you're going to do in the fall. Cross country, all of those things are from a pediatrician. The urgent visits, the I'm sick, I have a sty. So this is also so cool that I find so cool that I see so many different things. The office day is actually very exciting and unpredictable, right? Yesterday I removed an earring, like a 6-year-old had her ears pierced, and that stud, like the round ballpark, got stuck inside her lobe. So I had to remove that. And then I went to another room whose kid was having bloody noses because of allergies. And then I went to see somebody else with a broken hand from a fall. So lots of different things. And I think it's very exciting. Even though we're not interventionalists, we still do procedures. Like I said, the removing of the earring, that took a little bit. We also do Nexplanon implants. Those are like birth control in the arm. So we'll put those in. We remove ingrown toenails. We do circumcisions on little babies. So so if you're like, I like doing stuff, I'm good with my hands, we have plenty of procedures there. And I would say it's broad, right? Those examples that I gave were for medical things. I need to take care of someone's ingrown toenail that's infected. But there's also the social aspect of how they feel, how they fit in, their moods, which, as you can imagine, in teen years is a huge spectrum of sadness, depression, anxiety, all of that. So they come to their doctor for that. How long does it usually take to study to be a pediatrician? That was my slide in terms of like, do you mean specifically like, so that was the college, medical school, and 3 years of residency. So 11 past your 12 years of high school. That's how I gave the 23 years to my patient. Does that answer your question? And if not, just type it more specifically, and I'm happy to explore that. Okay, next slide, please. So this kind of goes back to the typical office day question. I start seeing patients at 8:30. I like to get in there at 8 so I could review. So my day on the left, it talks about schedule of patients. So I'm in the office. I see patients in the office who physically come to the office and see me. And these days, telemedicine, which are the phone appointments, who they just call and need advice on something, or I see you on video. Maybe you want to show me a rash. Maybe you want to show me a sty on your eye. So I also do video appointments. When I get in there early, I'm looking at everybody's chart, so I'm familiar. And I think the beauty of a pediatrician is I know so many of my patients, because not only do I see you, I see your brother, and you were already there when your brother came. So I see people over and over again. So when I look at my schedule, I usually know the name, and I'm like, oh yeah, they're here. And I already know a little bit about it, because when they were here with the brother, the sister told me that her toe was hurting. So I love that part. So I already am pretty familiar. I respond to emails that patients send me. I do phone calls. I check labs. That's what results are. So I've ordered labs on somebody, and then I have to review it to see, oh, do they have a UTI? Do they have a bladder infection? What medicine am I giving them? And I also get to rely on consultants. So if the UTI, the bladder infection, I've done a couple antibiotics, it's not working, then I call the infectious disease doctor, or I call a urologist or a nephrologist, which is a kidney specialist. So I have time to do that. I attend meetings. I think if you're going to be in medicine, not only in medicine, but in healthcare in general, you have to learn, you have to love lifetime learning, right? Things are ever changing. I've been doing this for 23 years. Ways that we treated an ear infection is very different then than now. So I'm constantly learning, constantly making sure I'm up on the latest and greatest about anything. So you just have to be someone who's curious and constantly wants to learn, right? If you're like, I just want to know one way, that's probably not, I can't even think of a field. Even I imagine if you're an AC installer, there are going to be new models. So you're going to have to learn new stuff. So I think that's just how the world runs these days. So I attend meetings so I can learn new stuff and to keep up with ever-changing science, because it's new things, which is very fortunate that we are able to do that. I think, unfortunately, these days, I worry about whether or not science is going to forge forward with sort of how it's seen in terms of funding, but I will keep that out of this talk right now. Okay, next slide, please. Okay, so my typical schedule, like I said, to me, it's still so exciting. I've been doing this for 23 years and folks are like, aren't you bored? No, how can I be? This sometimes is my daily schedule, right? I can have a 2-day-old on it. I can have a 6-year-old with a finger. These are all real. When I was making this slide, I decided to look at my schedule for the day, and this is what appeared on it. A finger burn from my mom's hair curler. She felt horrible because she forgot to unplug it. An 18-year-old who's off to college and wants to say goodbye and one last time, and I'm doing her vaccines and signing her form that was to Cal Poly. 3-year-old twins. Any twins here? Anybody who's a twin? No? I have twin daughters. Anyway, so they both had hand, foot, and mouth, which is an infection. An 8-year-old who lost 18 pounds in 3 weeks. That sounds super, super serious. That person ended up having diabetes. 7-day-old with bloody stools and vomiting from camping. 15-year-old who's sexually active, but parents don't know. That's a huge part of pediatrics. We're known as, we have the patient in front of us, the kid, the child, and then we have the adult, the guardians, the parents, the family. I hope, it used to be we're like, oh my gosh, we love the kids, but we don't love the parents. Don't let that not have you go into pediatrics. I think it's amazing. I think the whole dynamics is great. And people are, for the most part, reasonable. I think parents come across angry because they're just super worried about their kid. But I love that part too. And so this one, who's sexually active, because of California laws, I can't disclose to the parent what the child is telling me. So that's usually an art, a dance of what I can share, which is not a whole lot, but then again, but the parents are there and they have to go to the pharmacy to pick up medicine. So it's there's an art to it. I'll leave it at that. A 4-year-old, trouble breathing after eating cashews. That was an allergy, a food allergy. And then a 9-year-old with ADHD who's been struggling at school. And the parents are fighting over whether or not he should have medicine. So, I mean, what an exciting day, right? And so if you're that is the whole broad reach of pediatrics. Next slide, please. So I think to sum up, a pediatrician is so much more. Yes, first and foremost, I'm a clinician. That picture is a kid getting albuterol. Like that is a medical disease, asthma in your lungs, inflammation, airways. But as I alluded to, I'm a therapist. Yesterday, somebody came to me because she was stressed, overwhelmed, and anxious. And I asked if she wanted to see a therapist. And she said, no. She said, I don't trust anybody else. I only want to talk to you, Dr. Jan, which it felt really good. But then I had to convince her that I don't have the skills to help her through this journey. But people start to trust you, like patients, no matter what you do. If you're a surgeon, like people just inherently will trust your healthcare provider. And that's just a beautiful privilege. And I don't want you to forget that, like, take that to heart and take that to mean something to you, that people are sharing their secrets that they may not share with other people, and they're just offering it to you. Listening skills, because they're offering lots of details to you, you got to be a great active listener, which I hope many of you are right now. Just actively listening, not like I'm hearing you, but like actively hearing, listening, engaging. An advocate. I know that's a fancy word, but I speak for the little person who can't. So if the little person is sick and the mom's like, oh my gosh, I need you to do everything. I want blood tests today. That little 9-month-old is like, who's speaking for that 9-month-old who may or may not need to get poked? And the mom's like, yes, I want blood draws. So I become sort of that person speaking for the 9-month-old, really calming her down and saying, look, this is this. Let's wait a couple of days. Maybe we can do blood tests later. And even though the 9-month-old doesn't thank me yet, doesn't know how to say it, but I think he appreciates not having, to get a blood test that's unnecessary. So I have to become an advocate, like really caring for the patient. Who's 0 to 18 years old in my world. You're being a cheerleader. You're high-fiving them when they do something great. I had lots of kids, elementary, who had their like 4th grade promotion, and I was super proud of them. So little milestones along the way like that. So all of those reasons are, all of those roles are what a pediatrician would play. Last slide, please. And I think that's my very last one. If you guys are Kaiser Permanente members, I am on the website that they have. That's me many years ago, but I threw that in to highlight the little patient. I mean, look at that trust. That was a patient that I met that day of the photo shoot, and he just let me look in his ears. Like it was just such a beautiful connection that you as a physician, as a provider, get to connect with people. And so that, I think, is one of the reasons that drew me into medicine and has kept me there for many, many years. Thank you for your attention, and I wish you so much luck. And I've pride already for you for spending your summer doing this online program to learn more about different aspects of medicine, of healthcare. So that's the end of my formal presentation, but I'm happy to answer the questions. And I think I want to round back up to what do you recommend in taking undergrad higher education studies if you're planning to be a physician? My short and sweet answer is whatever you're interested in. Of course, there are the cores that are a pre-med needs to satisfy, right? Those are, and I'm not going to know them because they're ever changing. But if you look on the websites, like there's a certain amount of chemistry and biology and physics and all those classes that you would expect a scientist, that's what physicians are, a scientist to know. But in terms of what classes, I've sat on admissions committees for medical schools, for residencies. We want a person who's passionate. Remember how I said it's somebody who learns their whole lives. I don't care if you're learning about the life cycle of a bumblebee, but the fact that you know that so well, and the fact that you've been, I don't know, learning about honey and having a I don't even know about bees to like continue my analogy, but you know what I mean. Like you've learned about it for 12 years. That shows me that you are a cool person who is passionate about something and pursues that, even though bumblebees weren't the coolest things in the world, but to you they are. So we want to see passion come through in whatever you do. So you can be like you can do an archaeology major, you can be whatever major, mechanical engineering, as long as you satisfy those classes. So I don't think there are classes that you have to take, but do something that you love and you're truly interested in, that will come through. Personal challenge in face the way of becoming a pediatrician. Oh gosh. I don't know if you want to know my personal story. I think maybe you're adding sort of broader context. On the way to becoming a pediatrician, I think it's still, even though I think pediatrics has the shortest, one of the shorter residency programs. Remember, it's only 3 years. It's still a long time. It's still a long time. And so by the time I was done, let me do the math real quick. I was like 28 years old. That's old. That's an old person, you guys. And I think the harder part too was that many of your friends who go through college with you and get a job at Google, like they're already earning a paycheck, a big paycheck. And you're like, oh, I'm still in school. Like that, I thought was a little bit hard. I didn't go to my 5th year college reunion because everybody had like, oh, I'm doing this and I'm flying off to this and I invented this and I have a startup. And you're like, I'm still in med school. Like it just didn't sound very exciting. But in the end, I would say I'm gonna turn that around. I think the biggest bonus, and I tell this to my daughter too, who's interested in medicine, is that I've stability in my job. I've been here for 23 years. I have no desire to leave because I do lots of other things. I oversee the wellness program. I teach medical students and residents. But if I'm pretty sure, and I'm trying to not to, as my daughter saying, I'm not trying to flex, you guys. But if I want another job tomorrow, I'm pretty sure I can go out and get one, because medicine is just like that. Versus people in startups, like they go from job to job to job to job, which is exciting. Again, if that's exciting for you, that's cool. But to me, I don't ever want to interview and look for another job. So stability is what I've got. And I think most of you in medicine, if you pursue that, will have that. Balance personal life and studying in medical school. I heard it's very demanding. I think it's very doable. Yes, it is a lot. I will say, I oversee the wellness programs for my colleagues, and I know working with medical schools and residency programs, people are realizing it can't be as hard as when it was before. Like I literally lived in the hospital for like 36-hour shifts, and that was insanity, you guys. Like that was hard physically and like emotionally, but that's what we did. And people are realizing we can't do that anymore. Like that's not okay. People make mistakes when you haven't slept for 36 hours. So things are becoming easier. And I think you just have to go in it being aware. Like, can you drop everything and go to Boston for 3 days because you want to? Maybe not. I give you that we do have to prioritize. But if your best friend's getting married in Boston, yes, go for it. And then come back and sort of see what how you have to make up for the lost time. So I think there's always an opportunity to balance. And I think I usually give another talk about wellness, and it's really from the beginning, developing habits, like knowing what kind of things gives you self-care, whether it's exercise or reading a book or crocheting, and really pursuing that so that there is balance, even though external factors like medical school residency is trying to sort of take you off that stability point. But you're like, I've got this, like I've got my core group of people who support me, my friends who make me laugh. So when hard stuff hits you, you're still okay. All right. Roadblock studying in medical school. I don't know. Roadblock sounds fancy. Like, I think it was just that. Like, I was obviously younger and I probably didn't know how to balance as well. So I think that would be the biggest thing that I would share to you guys. Like, go into it with a global view, know what's important, and then just set your like non-negotiables. Like you are a runner and you're going to run 3 times a week no matter what, and that brings you sanity. So keep that as a non-negotiable, and so it won't be like things will be affecting you. But medical school, I will not lie, it's a lot of knowledge about the human body coming all at you. I was a poor test taker. That was probably hard because you got to take all the licensing exams and SATs. Like I didn't do well on standardized testing. I just don't think that way. I overthink. But in front of a patient and a verbal exam and an oral exam, I can kill those. So I think again, it's who you are and what your style of learning is, and getting to know your strengths and weaknesses early on, so you can work on them. Okay. How did you manage that, like going through this pathway? Yeah, again, it takes a village. I know that's a saying, and many, probably some of you have physician relatives or parents maybe, and you've been raised by a village. We had I had three kids. I have three kids, and when they were little, it's like three kids under 2 years old. It was like a zoo at my house, complete circus. But I worked the whole time. My husband is a surgeon, so we relied on grandparents, on nannies, on a lot of outside help. And then you just do it, because if that's what's important to you, and that was important to me, you just do it, and it will work. And maybe a little bit of sleep was lost, but it was all worth it. Now my twins are 18 and my oldest is 20 years old, and it's all good. It's all good. You can definitely manage an awesome personal life, family life, with a career in medicine. You got to love it. You got to want to be here. If you're unsure, let's get you to a place where you're like, yes, I'm sure those sacrifices will be worth it.
All right. Well, thank you so much, everybody. Thank Dr. Chan for being on the call. That was a really great overview and a good start, since we're going to hear from a lot of different specialties, a lot of different jobs. So it really is a good start, a good foundation for them moving forward. So thank you very, very much. And good luck with your daughter's move out.
Gotta move right now. Okay, bye, guys.
All right, bye-bye.
Bye.
So we're going to take just 2 minutes. Our next speaker is going to be Dr. Stephanie Smith. We're just going to take 2 minutes to, if you need to run to the restroom real quick, and then we'll get started. Hi, Dr. Smith. I hope your cat's okay.
How are you?
I'm good. I hope your cat's okay.
She's under right now, so we'll see how it goes.
Oh, geez. Okay. Well, we're just going to give him a couple minutes to take a quick break, and then we'll get started.
No worries.
All right, let's get started with our next speaker. So Dr. Stephanie Smith is a clinical psychologist who has lived and practiced in California since moving here in 2015 for her residency with Kaiser. She has practiced as a health psychologist, testing psychologist, therapist, and a professor. In her free time, Dr. Smith volunteers on the board of the California Psychological Association. as an executive board member. She had 4 majors in college before picking psychology as her 5th and final major, and is excited to share her experience with you. So welcome, Dr. Smith.
Thanks so much, Sam, and hello to all of you. It's nice to see at least some of your faces and some of your names. So as we go, I'm going to share some slides. They're super, super, super basic slides just to have a little bit of background to kind of what I'm saying. Let's see. Hopefully those are showing up for all of you. Can you see them?
Not yet.
Not yet. Okay, what about now?
There we go. Got it.
Okay. Okay, great. And you're mostly seeing the slides, and then I'm like a little
Yes,
thing inside. Okay, perfect.
correct.
That's how it should look. Okay. So I'll talk with you about behavioral health careers in general. I am a psychologist. Of that will be kind of my perspective. When I'm in clinic, I go by Dr. Smith. I'm actually East Coast, I'm Maryland, and like Sam mentioned, I moved out here to California for residency with Kaiser. And that residency was as a health psychologist. So health psychologists are a type of mental health or behavioral health provider that works in hospitals and typically works with people where there's kind of some interaction where their physical health is impacting their mental health or vice versa. So maybe the pain that comes with someone who has a cancer diagnosis, or someone's gotten a diabetes diagnosis and they're having a hard time kind of keeping up with their regimen. Health psychologists might deal with that kind of thing. So I worked with Kaiser for about 10 years, and as you can see here on the screen, I've worked in a number of different settings, some forensic settings like a jail, some neuropsychology, and then lots of hospitals. So right now, I'm doing individual therapy and couples therapy, as well as psychological testing. I should also have added in here that I was a professor for 3 years, and I don't think I listed that out. So also worked at a school as a professor teaching doctoral level psychology classes. So one of the cool things, and what you'll kind of see, I think, thematically as we keep going here, is that you can do like all kinds of things with behavioral health. It's a really cool career because you're just not limited in basically any way. There's so many things that you can do. So what people mostly think of behavioral health providers doing is exactly what they do. So a lot of behavioral health providers, that's psychologists, that is psychiatrists, who are people who have a medical doctorate degree in mental health. That would be master's level providers like social workers. In general, most mental health providers are providing some sort of therapy. And when we look at therapy, we're essentially looking at what is the connection between someone's psychological health and the other things that are going on in their life. So we want to kind of take a look at what is holding someone back from their goals. So I've got a couple of examples down here. I think my head is in the way of one of them, but whatever, I'll kind of go through it. So an example of that might be someone who has a lot of anxiety around failure might not try very hard because they don't want to fail. And if I don't try, I won't fail. But if I don't try, I also wind up not getting anywhere. And if I don't ever try out for the sports team, or I don't ever try to take the test to get into school or whatever, then I don't actually get on the sports team. I don't actually get to go to that school. And that over time can make me even more anxious because I'm not achieving my goals, and that's stressful. And so that cycle could be really, super, super hard for someone to deal with, in that their anxiety is kind of keeping them from doing what they want to do. So a behavioral health provider might help someone kind of recognize what's going on with that anxiety and help them work through it. Similar thing kind of in this example below with depression and alcohol. Alcohol, for lots of people, say, it just makes my stresses fall away. The world is all good. But the alcohol then can also cause worsened depression. So it can be a cycle. Oh, I see a message that says the internet's unstable. I'm going to switch connections, but that's going to that'll probably take like a minute or two. Let's see. All right. Hopefully we're reconnected now. Sam, is that any better? Okay, a little bit. Okay, great. So we'll go ahead and keep going. Hopefully you were able to hear at least some of that. So that is really reduced, but kind of in a nutshell, that's what behavioral health providers do, is try to understand these cycles that are going on for folks that are kind of between them and what they want out of their life, between them and their dreams. There are a lot of ways that therapists can provide that kind of help. There's so many different techniques. So, if you've ever been in any kind of mental health setting, you've probably heard of some of these, teaching someone how to communicate, right? If I've got a lot of social anxiety, I may really say, like, I just need the basics. Like, what are good conversation starters if I'm at a party? What's a good way of introducing myself to, somebody who's like cute and I want to ask them out? Like, how do I do that? So sometimes a therapist might actually walk that through. Like, how are you going to approach someone that you think is super cute at a party? So that would be one way. Other ways might be things like, we're going to do some journaling, or we're going to do some breathing techniques. So it can look so wildly different. That's one of the things that I love about doing therapy, is that I might go from a session where I'm processing someone's grief and trauma into a session where me and my patient are just laughing, as we like try acting out a dating scenario to get them more comfortable, and that can be really, really funny, and also, hopefully helpful. And then I'll go right from that into something totally different. We're talking about somebody's dog phobia, and working towards being able to walk the family dog, or a needle phobia and being able to get, a set of shots or that kind of thing. So it's so varied, and so much of it, because it's human beings, right? And we're very funny. So much of it is just fun and really lovely. You're just kind of having a chat with people, and they say silly things and you sometimes say silly things, and it can be really enjoyable just being able to kind of do that and support people. So there's a lot of different ways that can look. Not all, indeed, most people who provide therapy all have a little bit of a different way of doing it, and that's a beautiful thing. So, you probably know from making friends that you're a great fit for some people, and they like pick up on your sense of humor and they love how you are. And then you talk to somebody else and it's like, we just could not click. They probably think I'm an idiot. I kind of think they're an idiot. Even the best therapist in the world isn't going to be the best fit for everybody. And that's one of the beautiful things about therapy, is that it really is this process of finding the people who are a good fit for you and where you can really help support them. And where that's not the case, it's pretty immediately obvious usually. They can go find a different therapist, and the ones where it is a good fit, it's just a wonderful feeling. I was just in consultation group with other therapists the other night, and we were just talking about, like, I love my patients. I'm so proud of them. I think they do such amazing things. And it's so fun to be able to have a career where you get to support people and feel really good about that at the end of the day. All right, that said, there are so many non-therapist ways of being a behavioral health provider too. And if I'm honest, I've spent actually half of my career not doing any kind of therapy. I've always had a therapy practice for the most part, except for maybe a couple of years. But half of my practice now, and maybe even more, is I'm an assessment psychologist. So I meet people just one time, just for a diagnosis. And that type of work is really interesting to me. It's really exciting. It's a totally different part of my brain. It's a very analytical, I'm going to connect with you, but for like 2 to 4 hours. And then that's it. We're not going to maintain a relationship here. And that can be really nice. Some people say, I'm really not a touchy-feely person. I'm not somebody who wants to go to work and be like, I love my patients. That ain't me. I want to go to work, do my job, and go home and not really think about it a whole lot. Assessment psychologists get to do that. And then that's half of my job, which I really like. I've got a certain amount of battery for touchy-feely, lovey stuff. And then I'm done. I don't want to do that anymore. And so it's really nice in psychology that you can do a wide variety of things. So assessment psychologists don't do therapy typically, or like me, they do it only like totally separate parts of their job. You could be a researcher, you could be a professor, which again, I mentioned I was a professor for about 3 years. Again, totally different way of being. You're just with students, no patients at all. You could be a supervisor, which I've done. You could be a manager. So you're just really quite administrative. And so in those types of roles, you may have some kind of clinical workload, but you're also administrative. You're working with scheduling and money matters and that kind of thing. And there are lots of mental health providers who start in patient care and clinical roles, and then they work into administrative roles and really don't do a whole lot of patient care. They become kind of business people. And I love that. You know, there's a lot of mental health providers in public policy. I work currently as an expert witness, so I give testimony in court pretty regularly about my opinions of someone's ability to function. So if you're looking for a career where you can be like, what setting do I want to work in? I could work in any. That would be a behavioral health provider because we're just dealing with people. We're everywhere. Lots of behavioral health providers work as consultants for businesses. So they will make recommendations for HR policy. They'll help kind of work through administrative kind of workflow stuff. So I believe the pediatrician who was speaking before me was talking about kind of some of the differences in like a hospital-based practice and something like going, you know, and working for a tech startup or something like that. Behavioral health, I would say you could go and work for a tech startup also, or you could go work for a hospital because we're just everywhere. You know, you no matter where you go, if it's a human being thing, there's probably a role for a behavioral health provider. Because anything that's got people is going to have some people problems, and that's kind of what we do. So it's pretty fun to be able to do that kind of thing. These types of behavioral health providers help by doing management, by studying the impacts of things, creating recommendations through teaching, through advocacy. I mean, sky's kind of the limit. You could sort of do whatever you wanted to do. So let's talk a little bit about the pros about behavioral health careers in general. And there's a lot of them, as you can probably hear. For those of you that do take meaning in the work of helping people, this really ticks that box. I'll be honest with you, that was a 0% motivation for me when I became a psychologist. And I'll talk a little bit more about that in a couple of minutes. But if you're kind of like, I'm really going into healthcare because it's stable and my parents told me to, and I think there's decent money in it, that's a totally legitimate reason to go into any of these careers. This particular one, number one, I now care about that. I didn't care when I was your age, really, about helping people. You might, and you may be much better people than I was when I was your age, but that doesn't have to be a meaning piece, but this will do that for you. The physical demands are typically quite low. And for me, I think that's an important thing if you're thinking about a career that you might want to have for a long time. Most of us will go through periods where our physical abilities are not the same. You know, as we get older, you might break a leg, you might have a baby, you might develop some kind of condition and you're not able to scramble under a car or do some of the physical types of things. The physical demands as a behavioral health provider are low. You're mostly sitting. This is the type of thing that you generally get better at as you get older. So I've been a psychologist now for about 15 years. And I cringe about some of the things that I said 15 years ago as a psychologist. I'm like, God, that was not the best. I could have done that way better. And I know that 15 years from now, I'm going to cringe about the things that I'm saying today. So it's one of those things that you just get better at as you get older. So again, unlike something, again, I'll use tech as an example, learning new things like tech typically is harder for older people. Our cognitive functioning, as a neuropsychologist, I can tell you, our cognitive functioning really goes down after our mid-30s. This is the type of career that you actually build upon as you get older, so it's easier on your brain because you will get better. Whereas in some careers, you may have more challenges as you get older. It's pretty well paid, generally pretty good benefits. Not well paid if you were to compare it to something like a surgeon, I would say, but well paid if you were to compare it to something like a primary care doctor or a pediatrician, that kind of thing. More on that kind of level. And the benefits are usually decent. Unfortunately, but great for job security, mental health providers are always going to be needed. bad things continue to happen, difficult times continue to come up, this career is not going anywhere. Chatbots thus far are very, very, very poor in terms of their mental health outcomes. So we're doing well. There is a lot of variety, as I mentioned, so you don't have to feel stuck in one thing. That's one of the things I've been so happy about as a mental health provider. The pediatrician who was just speaking was talking about, or I heard the tail end, and she was kind of mentioning, I love never having to apply for another job and just doing the same thing every day. And I've got a lot of colleagues who do that with behavioral health. I am the opposite of that. Every couple of years, I'm like, oh, right, what kind of trouble can I get into? Let me do something else. I'm kind of curious. And you can do that in behavioral health, and it's not a bad thing. So if you're somebody who is a little bit of a rolling stone and you want to try different things and you get curious, this is a good job for that. You can kind of keep it moving if you want to do that. Or if you're a stability person, you can just work a 9 to 5 or whatever hours you want to set, go to work, do the same thing every day, come home. You could do it however you wanted to in this kind of job. The work in therapy is solo, but there is a large and supportive community for most people. So I mentioned I'm in a case consult group for therapy. I'm also in a case consult group as a testing psychologist. I work on a board. So there's all kinds of support and community. And of course, personal growth, right? Nobody's perfect. When you go to school to become a psychologist, if you do that, you will probably go through a period where you're learning about mental health conditions and you're like, I have every freaking one of these. I am this, I am this, I have all of the conditions, or if I don't have it, one of my family members does. And so there's a whole period where you're learning about mental health conditions where you will be convinced that everybody has something. And then you kind of go and you learn more and develop more concept around that. But there's a lot of personal growth in that and just kind of learning how people work, shining a light on like, yeah, I was a jerk then. Why did I do that? Let me learn about myself so I can do things a little bit differently. There's a lot of personal growth in this type of work as well. You can learn a lot about yourself and about your family and everybody else that you interact with. There are some cons, of course. This is not an exhaustive list. So again, for those that do take meaning in the work of helping people, this can break your heart. Just like all kinds of medicine you may have heard from other people in medicine. Anytime you're dealing with people, there's going to be things that you can't help them with, that they're coming in with pains and traumas and things that you can't undo. And there's some stuff that can't be fixed. You can help people deal with it always, of course, but lots of things can't be fixed or they can't be undone. And that's hard sometimes. That's not always the case. There's so many more triumphs, at least in my work. But to be realistic, there's some hard things that you will have to deal with, and that's true in any kind of medicine. They wouldn't be coming to see you if things were always awesome. You're going to have to hear some difficult things sometimes. We mentioned that there's not a whole lot of a physical component in this job, and that can be really good. But as you can probably tell, I'm super active. I'm a person with a lot of energy. So having to sit all day would kill me. And this job can be hard with that. So taking breaks, needing to get up to go, like actually go out for a walk during lunch, exercise before work, do something else during the day. I've got a sit, stand, a desk, and I use it all the time. I like testing because it's much more active than just talk therapy. So if you're a person who's pretty hyperactive, you will have to make some modifications to that regular just sit at your desk and talk to somebody type job because it's not physical. It's not very active. You'll have to make yourself take the breaks. Schooling can be expensive. That's true in all of medicine, I think. And that sucks. I'll be just frank about that. Having a lot of student debt is awful. It sucks to be in debt. I'm not in debt anymore, and that feels fantastic. And now I get to keep my paychecks and I don't have to pay it back. But when I was still paying that back, that sucked. So I think that's true of pretty much all of medicine. But it's realistic just to consider. There's a lot of kind of financial crippling with that. The amount and type of demand can be draining. So if you want to save the world in any kind of medicine and you take on too much load, that will burn you out. That's true in behavioral health. That's true in every kind of health, because there's always more people who need your support. So setting your own personal boundaries is pretty essential in this job. If you have a hard time with that now, you will have to learn it if you become a behavioral health provider. Okay, I'll go ahead and keep going, and then we'll have some questions at the end. So what's required? It depends a lot on what you do. So I have a PsyD, which is one of those ones at the top. It's a doctorate. PsyD stands for psychology doctorate, whereas PhD stands for philosophy doctorate. PsyDs like me mean that we went to school to become clinical psychologists, meaning I wanted to practice with patients. I didn't really care about research. I actually care a lot more about research now, but when I went to school, I was like 21 or something, and I was like, I don't want to do research. So I got a PsyD. PhDs tend to do more research. That's not always the case, but anyway, both of those people, they're going to do the most schooling, and that means you've got a bachelor's degree, and then you've got 5 more years of schooling on top of that, usually a 6th year of residency after that, of specialty. So it's a long time. It's a long time in school. Master's level clinicians, they do their bachelor's degree, and then they do another 2 years, and then usually 1 more year if they want to specialize in something kind of like a residency. Bachelor's degrees, that's just, it is what it looks like. It does what it says on the tin. You just get a bachelor's degree. The more schooling you do, the more opportunities you have. Meaning that you have more options of types of work, places you want to work. You typically make more money. So there's more options with that. I would say a master's level clinician can get to the point of doing almost as much as a doctoral level clinician. It's just going to take them longer to get there. They're going to have to generally have more experiences, but they can get to doing a lot of what psychologists can do. They're never going to teach a psychology class, so they won't be a professor. And they're never going to be able to do psychological testing, and they can't do anything with prescriptions. But if you just wanted to be a therapist, if that's all you wanted to do and you just wanted to do therapy, I would say get a master's degree, because if you're not interested in research, you don't want to do testing, you don't want to do prescriptions, if you don't want to do any of that stuff, get a master's degree. There's no point in getting a doctorate. If you want the variety, if you want the options, you're going to have to go all the way. Bachelor's level clinicians usually just have certifications to do one specific thing. So they may be just ABA therapists, so they just work with kids with autism, for example, and that's the one thing that they do. So they have the least flexibility. Typically, they might only work with people with substance use issues, or, it's just one thing. They're just certified to do one thing. So again, just fewer options, less pay. All right. So the question I get when I typically give these kinds of talks is that at the end of the day, essentially you're here for yourself and you're trying to figure out, is this right for me? So my answer would be, I have no idea. I don't know you. I don't know if this is a good fit for you. At the same time, you probably can't know that either at this point. You know you about as well as anybody possibly could. And trying to figure out what you're going to do for the rest of your life at 17 or 18 is a crazy thing to say. You've probably only really been realistically thinking about it for 10 years. How could you know at this point? And I'll kind of come back to my own example. I went to college to study business, and I wanted to be a hotel owner or own a restaurant, because that was the experience that I had had. I was a bartender at that point. Back then, you could be a bartender when you were 18. Anyway, so I went to school to study business, and then I was like, okay, I think maybe I don't want to do these math classes, so I'll do communications and advertising. And then that was pretty boring. So then I was like, well, maybe family studies. I had one of those classes, and I was like, I hate all of this. I just want to do art. And so then I was a ceramics major. And then I realized that's not going to make me the kind of money that I want. I really like stability, and this makes me anxious. And so then I realized, you know what? I consistently stay awake in psychology classes. I think that's what I'm going to do. So this is not a starry, wonderful example of how to decide what you want to do with your life, but it's also a really real one. I went to school and I studied psychology, and I graduated with a psychology degree because I could stay awake in those classes. I went and got my doctorate because my dad said, what are you going to do with a bachelor's degree in psychology? You have to keep going. And I was like, well, all right. So I kept going because I had no concept of student loans at that time. So I was just like, all right, I'll sign that paper. Um, and that's okay. It's okay to be doing that kind of thing, to not be sure and to go to school and to figure it out. It's what I did, and it has worked out for me. So just to kind of keep in mind for you as you're going, most people are going to have to try some things out. And lots of us have many, many, many potentials. There might not be one right thing. I think I probably could have been a good restaurant owner. I think I probably could have been okay in advertising. I wound up doing psychology. And it's okay that I've had all of these other potentials that didn't happen. You might be in a place where you're looking around and saying, like, I like everything. Every presenter who's talked, I want to do what they wanted, what they're doing. It sounds so good. Or you're sitting there going, all of this sounds awful. I can't imagine doing what any of these people are doing. I don't want to do anything for the rest of my life. And I felt both of those ways. It's a lot to think about the rest of your life. It's like slapping on the handcuffs right now. It's too much. And I still feel that way occasionally, like, gosh, am I going to do this forever? And the answer that I always have for myself is maybe, or if I don't want to do it, then I won't. I'll figure out something else. And that again is one of the nice things in behavioral health is you can do that. The size of our student loans are typically about half the size of a medical school student loans, so it doesn't take nearly as much time to pay that off for most of us. But just to have a little bit of grace around that. If you're feeling unsure, if you don't know what you want to do, that's okay. If you're like, I don't have a good motivation for picking something, I chose a major because it was what I could stay asleep doing. I went to graduate school because my dad was like, you should probably do that. And a boy I had a crush on was also going to graduate school. So I was like, well, those are two good reasons. Here I go. And that was it. Also, we don't even talk anymore and I have a different husband now and that's all good. But, you could have a totally bad reason for doing something and it could still work out okay. So if you're not sure, or you're feeling like I need to have a super good reason, that might not necessarily be the case. And to some degree, at a certain point, we just have to kind of pick a thing and make it work. All right, I know we only have a couple minutes left, but if anybody has any questions, I'm very happy to answer them. Someone said, what is the most challenging part in diagnosing people with any issues they previously had in their life? Well, I would say there's two things that I would describe as the most challenging. One would be people are complicated and we don't always see things in an accurate way. So someone might give me a history of their life and then I ask their parent about their life and they tell me something totally different. So that can be challenging, is getting different perspectives because we all see things differently. I would say the other most challenging part in terms of diagnosis is that many people now with the internet have looked up their own symptoms. They know what they think that they have, and they're kind of committed to that diagnosis. And I might say, I don't actually think that's right. I think it's this other thing. And that can be really hard to hear. When you've committed to something, you said, this is my diagnosis, and these are my people, the other people who have this diagnosis. And then I'm coming along saying, no, that's not you, and those aren't your people. That's a hard conversation. It can be useful, but it's tough. Let's see, someone says, what does a typical workday for you look like? What was something unexpected you learned when you entered? So now a typical workday for me is I maybe see a therapy workday is I see maybe 2 or 3 patients, and then I go to the gym, and then I take a shower, and then I eat lunch. So I take off for like 3 hours in the afternoon. And I come back and I see 2 or 3 more patients. And then that's it. So I will work like 2 to 4 hours in the morning, take 3 or 4 hours off, and work another 2 to 4 hours. That's a therapy day for me. A testing day would be I go into my physical office. It's not remote, it's in person. And I assess a patient for like 4 hours straight. And then I take off another 3 hours. You can kind of get this theme. Like I have a hard time working in the afternoon, so I take off another 3 hours. And then I write the report for another 4 hours in the evening. When I worked in the hospital, it was a 9 to 5. So I would go into the hospital, clock in, have an hour for lunch. And so that's just kind of like a typical 9 to 5. Someone said, do we have breaks? Oh, that's for something else. And then the last question here, what was something unexpected you learned when entering? So I think the unexpected thing for me was that I would care about my patients and that I would love them. I went in, as you can tell, I had bad motivations for doing this. I just wanted to make some money and I wanted it to be stable. And once I committed to it, it was just doing it. It really surprised me how much I would love people and how much I would enjoy it. And I just didn't think I was going to. Um, and that I think is the most surprising thing is just the capacity that we can have to really form strong, meaningful connections with people. Someone said, do you think your schedule is flexible or more demanding? My schedule is super flexible. As you can tell, I've decided I want to take off 3 days or 3 hours in the middle of the day, and I do. It wasn't like that when I worked in the hospital, so I kind of had to get to a point where I could have my own private practice. But if you have your own private practice, you're going to make your own hours. You're going to work when you want, and you're not going to work when you don't want to work. Let's see. I'll answer this last one and then I know we got to go. I took a psychology course this year. What did you learn in college and how in depth did it get? I would say college is like really, I just learned kind of background, just theory. And that was cool. That was enough to make me be like, wow, there's so many subconscious things that drive what all we do. And that's really interesting. And that kept me awake in those classes. But like your bachelor's degree classes don't typically go that in depth with anything, but they're kind of like the highlight reel. It's like when you get ready and psyched for a movie, it's like, oh, I'm going to learn so much more. And then going to graduate school is like watching the movie. Bachelor's degree is more like watching the trailer. So both are good. You know, you get like a lot of highlights in the trailer. It's all super useful and it tells you what's coming. And then you watch the movie. Okay, I'm sorry we're out of time, but thank you all so much for having me. It's been so nice to see your faces.
Yes. Thank you so much, Dr. Smith. That was absolutely wonderful. I was also a psych major in college and considered that as a career and then got into doing this. So it's not always a straight path. So thank you for sharing that. I really appreciate it.
Okay, my pleasure. Have a great rest of your day, everybody. Bye.
Bye-bye. Okay. So our last speaker for the day is Shannon McPartland. Shannon is a senior coroner technician with the Sacramento County Coroner's Office. This was always one of my favorite talks. The coroner's office is not one you might think of as part of healthcare, but caring for the deceased and their families is a huge part of healthcare. So I did an internship with the Sacramento County Coroner's Office several years ago, and it was one of the most fascinating experiences of my life. So I want to welcome Shannon McPartland.
Hi, everybody. Thanks for having me. My internet might be unstable, so I hope that you guys don't have a problem hearing me or seeing anything. I do actually have a PowerPoint, so is that something that I could share?
Absolutely.
All right. Let's see if I can do this. All right. All right. Can you guys see the PowerPoint?
Looks good.
Awesome. All right, so I'm pretty much going to talk to you guys about a day in the life of a coroner technician, which is what I am. So that is the sign in the front of our building. It's a very lovely sign. We share the building with the district attorney's crime lab, so that's who's upstairs from us. All right, so many of you may not know what the coroner's office does. So we investigate sudden, unexplained, or unwitnessed deaths that occur in Sacramento County. So not everybody that dies in the county needs to come here. If somebody has a doctor, like they have a cause of death, like cancer or something like that, they don't need to come here. Their doctor can sign their death certificate. But we are in charge of determining the cause and manner of death for those people who don't have a doctor or hadn't been hospitalized for longer than 24 hours. Our staff is made up of the coroner, an assistant coroner, two supervising deputy coroners. We have administrative staff, deputy coroners, a chief forensic pathologist, multiple forensic pathologists, the senior coroner technician, which is what I am, and then coroner technicians, and we all work together to accomplish that task. So while cause of death can be many things, that's kind of the exact reason why somebody has died. Things like, you know, certain type of drug overdoses or, you know, heart problems, or it could many things. Manner of death falls under one of 5 categories, which are natural, accident, suicide, homicide, and undetermined. So that's what we go with those manner of deaths, and then whatever the cause of death that the pathologist determines from the autopsy or the exam. So the duties of a coroner technician are we pick up decedents from hospitals and scenes. So we go out into the world and interact with people on the outside. So hospitals are a little bit more enclosed and kind of regulated, but we go to scenes. Many things can be happening at scenes. You know, I've been on the side of freeways. I've been at homicide scenes. It's so different all the time, which is part of the reason why I love this job. We also prepare the decedents for autopsy, which would be like processing the decedent. So we get their height, their weight, hair color, eye color, all of the stats that the doctor would need. We document any clothing, any property. We cut off clothing and we remove property. We generally will return any property to the next of kin. And then we also fingerprint the decedent, take photos of the decedent. If x-rays are necessary, we can also take x-rays, like anything to get the decedent ready for autopsy when that's going to happen. Then we assist the pathologist with the autopsy. So that involves some of our CTs are able to do the full autopsy. Essentially, they do all the evisceration and hand the organs to the doctor, and the doctor does the dissection of the organs themselves. We have people who help take the samples. We have assisting with autopsies. We also do paperwork, help take photos, enter all of the stuff in the computer, kind of all of that general stuff that we will do. We also prepare and send out the various samples for toxicology testing or microbiology testing, like any type of testing that the doctor feels is necessary to figure out why the person died, we will send out for testing. And then we also release the decedents to funeral homes once the family has decided what they want to do, what kind of services they want, that kind of a thing, and they've gone to a funeral home and started all of that. We will release the decedent to them. And then we also maintain a clean and an orderly just work environment, our morgue, our coolers, all that kind of stuff. It can get pretty messy in here sometimes. So a lot of what we do is just cleaning up after ourselves. So, like I said earlier, we do scene and hospital removals. So we respond to the scenes with our deputy coroners. The deputy coroners are the ones that do the scene investigation. They kind of go out and ask questions and figure out kind of what's going on. Our job on the scene is to manipulate the decedent so that they can take photos. We try to remove as much personal property as we can on scene so that we don't have to worry about bringing it back to our office. And then we put things on like handbags to preserve evidence if it's like a homicide or something like that. So we'll help the deputy with all of that. We then put the decedent in the body bag and then put the body bag onto the gurney. So like I was talking about with the kind of uncontrolled aspect of scenes, there are multiple issues when we're out there. So whether it's the families present, and families can range anywhere from, very angry that something has happened, very sad that their loved one has passed away. But also I've encountered, grateful family members who are glad that somebody is there to handle and take care of their loved one. Also, the layout of some places can be really challenging, whether I've been to places where like I need to go to the 3rd floor to get somebody and there's no elevator, so it's a lot of steps. Or the terrain of an outdoor scene. So we've been to accidents with with trains, and sometimes those can be spread out. The scene can be spread out over like a quarter of a mile. along the train tracks and along the rocky sides of the train tracks. So yeah, the train can really cause problems. People don't always die in the most convenient places to get to. And then we also respond to the hospitals. We'll do that without the deputies, and we will sign all the paperwork to release them from the hospital and bring them back to the morgue to be examined by our doctors. So then the processing aspect, like I said, we take the height, weight, hair color, eye color, document the clothing and property. Clothing we discard because it's a biohazardous type of situation. We don't want to return that to family if there's blood or body fluids on it. So we will just discard it. Anything that looks like it might be valuable, like belt buckles I've seen, or boots or something like that, we will try to clean them up as best we can and return them to the family. Identification photos are taken. Fingerprints, we do have a live scan machine where we can take them digitally and then upload them to the system. We also can do kind of like the old school inking where we put the black ink on the fingers and then roll them and to get fingerprints that way. And then the other way that we do is if somebody has been dead for a while and they've mummified, like they've dried out, and all of the like fluid is gone, so they kind of wrinkle and harden. We can use a silicone casting material that is generally used for tool mark analysis in forensics. We can use that to pull a fingerprint off of somebody that we wouldn't be able to ink or live scan in other cases. So we can do that. And then, like I said, we take x-rays depending on what type of case it is. Generally, we're looking for projectiles, so some things like homicides, suicides, or we're looking for types of like abuse. So we'll take x-rays of babies and children, like that kind of thing. So we can take x-rays. The type of exams that are performed, we have what is called the external exam, which is pretty much what it sounds like. The pathologist looks at everything on the outside, documents any trauma, disease, or anything abnormal. We take all the specimens from the outside. So we usually get blood on cases like that. We also take vitreous humor, which is the fluid in the eye. That can be sent out for testing if we need it. So and external exams are generally for things like naturals where there's well-documented history of disease, but there's no doctor, or something like a suicide, where we don't necessarily need to cut everything open to find the cause of death, like we generally know. Then we have a partial exam, which is where only a certain section of the body is examined in depth. So, and these are all in addition to, so they do the external exam first, and then we'll open up a specific area. So this is generally for like suicides when we need to recover a projectile. Somebody who, like an elderly person who has a documented history, a natural history, but they also have an issue with falling. So then you want to know, is the natural disease what killed them, or could they have fallen and there's trauma? So we'll open up the head to look for, blood around the brain and that kind of stuff, which would indicate trauma. Or somebody who has a history of pulmonary emboli, which are the blood clots that start in your legs and travel up to your lungs. So we can find them in the lungs, and then we get a cause of death that way. So for that case, we have specimens can be taken either externally or internally, depending on what we're opening. Same general specimens, blood, vitreous humor. We can also, if we're opening up the abdomen, we can get a piece of liver or gastric contents, like that kind of thing. And then we have the full autopsy, which is a Y incision is made and all the organs are removed and examined for trauma or disease, including the brain. We open up the head to remove the brain, and all the specimens are taken internally. So the femoral artery is cut so that we can get blood from there. Like I said, gastric, liver, urine, we can get urine from the bladder. All those things we would take samples of in case we need to send it out for possible toxicology testing or testing for like electrolytes or something like that, depending on what the doctor wants to look for. So when we assist with an autopsy, we begin by taking overall photos. So the doctor has, documentation of everything that's happened with the, if they have medical intervention or things like that on. And then once they've done the external documentation, we begin with the evisceration. There's a couple of different ways that we do eviscerations. There's Virchow's method, which is removing organs one by one, which is generally what we do if we're going to remove organs. Latoul's or en masse method, then Gaughan's method or en bloc, where you remove groups of organs together. The en masse method is generally used for babies because everything is so small that you remove everything all at once. En bloc, we don't normally do that. Sometimes we can, like you can remove the heart and the lungs together, the GI tract together, that kind of a thing, but it's not how we normally would do it. And the Rokitansky or in situ method, where the organs are examined, we don't remove them necessarily, but the doctor will take a piece of each organ to save for possible testing or to make slides out of to look at them microscopically. We do a lot of in situ autopsies on a lot of our overdose cases. So mostly they know what the cause of death is going to be, but they're taking the pieces just to make sure that there's no additional underlying disease that we should be looking for. So then we would be collecting the samples, like I talked about, the blood, the urine, all that kind of stuff. We can send it out for toxicology, which is looking for drugs and other things that shouldn't be in the blood. Microbiology, looking for infectious diseases, things like the bacterias or viruses, like those kinds of things. And then histology is where we send out the pieces of organs and they get cut into really thin slices and mounted on slides so the doctor can look at them under the microscope. They can also stain those slides so that they can look for specific things. So we take internal photos of anything that the doctor finds is important, pertinent, interesting. We sew any incisions that we make during the exam. And then a lot of what we do, like I said, is cleaning and restocking for the next time that we're doing an exam. That is what the setup looks like for the coroner techs and the assistants who are helping the doctor. We have scalpel handles, the thing that looks like a T that's called a T-bar. We have a sewing needle, Dura strippers, some scissors, forceps, all of that stuff we use while we're doing the autopsy. And that's kind of a backed up photo, so you can see the syringes that we use and the vacuum tubes that we use to collect blood and all of our different samples. And then that's kind of the doctor's side. So we have the clippers, which are used to cut the ribs. Once we get the Y incision opened, we need to get through the ribs. So we use the clippers, and then the saw is used to get into the skull. So we reflect back the scalp and then saw the skull. So then the last thing that we do is releasing decedents to funeral homes. So in order for our decedents to be releasable, they needed to have been identified forensically. So that would be fingerprints, dental, or DNA. So like I said, we do live scan, we do inking, all that kind of stuff. If none of the fingerprints come back, then we try generally to do dental. We have a dental x-ray machine here. We have a forensic odontologist contracted with us who can come and compare the antemortem x-rays that were taken while they were alive to the postmortem x-rays that were taken after they got here to us, and then can make an identification that way. If, however, there is no there's no dental records, we can also do DNA. We have a rapid DNA machine that we can run if we need to identify people. We can also send DNA out to the DOJ lab and have it compared that way as well. So we can get identifications those different ways. We also need to double check to make sure that the correct next of kin has signed. So there's a legal order that people can sign, and it's generally like spouse, children, and then so on and so forth. And part of the problem and what we need to really be careful of is that if there's more than one child, like say there's three, we need to have a majority of those children choosing the same thing, because families can bicker and there can be problems and somebody wants to do something different. So we need to make sure that we're, you know, following the law and going with what the majority of the family members want. So we have them sign all of our release forms. We collect a transport fee for the decedents. We charge a certain amount to bring them here and store them for the amount of time that we need to do the exam and for the families to decide how to handle the arrangements. And then once everything has been deemed correct, we remove the decedent to the funeral home's gurney and release them from our care. So are there any questions? I can't really see the, hold on. Okay. So do we take breaks in between? So we take breaks. Generally, we have two 15-minute breaks, which we take one in the morning and one in the afternoon. Generally, though, when we're doing autopsies, I'm kind of just going through and like autopsy generally until lunch. When lunch happens, we switch out so we can have somebody come in. Like if it's my lunch and I'm still like assisting with an autopsy, if it's not anywhere near done, somebody will come in and swap me out so that I can eat lunch. And then, because the whole thing is that you have to disrobe, you have to take off all your PPE, which can be a lot. It can be like plastic and the gown and all the stuff. So you want to make sure that, you know, if you're going to take it off, that you're going to be out for a minute. So yeah, we have half-an-hour lunches, so we break for that. But generally, yeah, you want to make sure that you're going through, but it's not too bad. Our doctors start generally at 8 and we're usually done by about noon, if not earlier. So that's nice. With autopsies, not with the rest of our stuff. My schedule is definitely flexible in that, you know, depending on what's going on, like if there's a scene, then I'm going to a scene. If we're doing autopsies, I'm there doing autopsies or, paperwork, or like every day is different. So it's kind of interesting, but it can also get kind of crazy because starting at 1:30, releases are starting, like funeral homes are coming, and if the autopsies aren't done, then we have people doing autopsies and we have people doing releasing, and then there's a scene, then somebody has to go to that. So we're kind of all over the place, but it's what makes it interesting and exciting.
I think the psychology question was from the last one.
Oh,
The next one is, how do you deal mentally with seeing all of these graphic scenes?
yes. So, one of the things that, we make sure of is that people have coping mechanisms. So yeah, we see some things that lots of people don't see. So, part of what's really cool about our management here is that we have a comfort dog that comes probably like every couple of weeks or so. So we get to, just hang out with animals and a dog, or I think they've even brought in a tiny horse, and we can just hang out with the animals and really, just sort of let all that stuff out of our brain and just forget about it, for that time. I also, if something really bothers me, I talk to my family about it. I talk to my coworkers, we make sure that we're doing all right and that what we've seen we're not gonna take it home with us, that kind of a thing. Oh, what do you do if the family doesn't want the body? Yeah, that's a big deal. And it's something that happens a lot, um, which is really sad, in my opinion. But so if a family either doesn't have the funds to be able to afford something like a funeral or a cremation, they're what are called, they're considered indigent, and so they can't pay. Um, or if they've decided they don't want anything to do with that dead person and let's say they had a feud and they no longer want to deal with them, then they are abandoning the body. So we have both of those scenarios, but they both end the same way. The county is responsible for taking care of that decedent. So we do the cremation. We have an indigent cremation program where we take the decedents out for cremation. We have a contract with a funeral home, a local funeral home, and they do the cremation and then return the cremains to us. So at that point, we will generally scatter the ashes at sea for those people who don't want the ashes, or people we have abandoned. So we will scatter them, or we can return them to the family depending on what they wanted. Um, what made me choose this career? So when I was an undergrad, I thought about going to medical school, and I went for an internship. I went to go get internships, and one of them was at a hospital, and the other one was here because I was interested in forensics. And this internship to me was so much more interesting and so much more fulfilling. And I knew right then that I wanted to do this instead of the emergency room that I was interning at. And so I changed gears and started here. How much margin of error do you have for the autopsies? I'm not exactly sure what that means. Um, Sometimes, like if we do an autopsy and you don't find a cause of death, like there's nothing obvious. That's where our undetermined manner of death comes into. I told you guys about the 5 different types of manners that we can have. If they can't find anything, and this happens a lot, like in babies, sadly, is that there's just no reason that we can see that they have died. So a lot of times we go with undetermined. So I don't know if that's what you meant by margin of error, but that's kind of the thing that I can think of. Um, how did I get into this career? I got into it through the internship. I actually went to apply for the internship back when it was a private company, and they said that there was such a long line for the internship that if I wanted to move to the front, that I could sign up, or I could get hired to work. And so I said, sure, why not? I can work like swing shifts on when I was doing my undergrad. So I was hired as an employee first and then started my internship. So that's how I got into this career. And then once it became county, I just moved over with the county and have been here ever since. How can information from the autopsy, collected from the autopsy, be used? So there's a lot of things that we can do with the information that we collect at the autopsy. So our website actually has a lot of our statistics and things like that from previous years. With the fentanyl epidemic that is happening, we keep track of how many people come back positive on their toxicology testing for fentanyl, so we can tell how many people that we've received that have died from fentanyl. So we publish those results. Um, some of the other results that we have are not necessarily from the autopsy, but like homelessness, we keep track of. With the homelessness, there's hypothermia, like when it gets really cold outside and people don't have a place to go. You can see signs of that in the autopsy, so we can document how many people we've seen um, who have died because they were outside and unhoused. Um, Also some of the traumas, like the motor vehicle accidents, domestic violence, I think is the other one that we track. So those aren't necessarily autopsy related, but they are, that is information that we gain through our investigations that we use in other ways. So it's a lot of like public health and general, just looking out for the community, trying to find ways to fix the issues that we are having on a societal level. So,
All right. I think that's all the questions we have. Well, thank you so much, Shannon, for being on the call. This is always one of my favorites. So I hope you have a wonderful rest of your afternoon, and we look forward to hopefully seeing you next year.
yeah,
So
no problem.
thank
Thank
you,
you for having
everyone.
me.
Thanks, Shannon. All right. So we are finished with our day. I do have a drawing. So the $5 gift card goes to Aryan Patil. Are you still on the call? You can raise your hand. I can't see all the names. Are you still on the call? Yes, there you are. Okay. I'll send you a $5 gift card through your email. So thank you all for being here. We'll see you again on Friday at 10 a.m. Have a good afternoon.